Hello, everyone. So we've just seen how to set up a robotic heart operation, from cannulation, exposure, robotic docking, and now we're ready to go. The first step in all robotic heart surgery, particularly valve surgery and mitral valve surgery and all related procedures, is to be able to safely open the left atrium, expose the left atrium, and then actually close the left atrium. So let's have a look.
So now with the DeBakey in the number 1 port, the dual blade retractor in the number 3 port, and the curved scissors in the number 4 port, let's now begin how to do a left atriotomy. The aorta is cross-clamped, aortic cardioplegia is being delivered, and the dual blade retractor is positioned in a fairly specific manner. Sharp dissection is utilized to open both ends of the atriotomy, and notice the position of the dual blade retractor. That allows it pointed towards the left ventricle to allow the aorta to continue to be perfused for cardioplegia. The LV vent is then divided in half, and I do that mainly in order to place this into the left inferior pulmonary vein to get maximum drainage in a nice clear field. Now, what about left atriotomy closure? I personally prefer a vertical mattress approach to allow for endocardium and endocardium to come together, as well as epicardium and epicardium. The anchor stitch is tied, and then a vertical mattress suture performed. Essentially, it's 4 bites per suture. And once this is hooked, the tissues are brought together to create a homogeneous suture closure. Now remember that the atriotomy is actually a curvilinear incision, and therefore the closure needs to be adjusted as such. Bringing the epicardium to epicardium, and often taking small bites, followed by slightly larger bites on the posterior side until we're out of the turn. Each step along the way, bring the lower edge to the upper edge. Once you've continued to get closer, I usually stop at about where the LV vent enters. Now, when moving to the left or cephalad portion of the atriotomy closure, I tend to utilize the DeBakey as the initial needle driver, then switch over to the actual needle driver to avoid movement back and forth between instruments. Then again, the vertical mattress closure, so we get excellent endocardium to endocardium and epicardium to epicardium opposition. Once the final stitch is done, I usually turn off the vents and finalize that stitch with a backward stitch and helping facilitate final suture closure from the table side. Now, moving to placement of pacer wires. Once the case is complete, I tend to prefer to place these before reanimation and before removing the cross clamp. This is done utilizing the dual blade retractor to lift up the pericardium if needed. Sometimes this is not required. Tend to break the stitches just with the robot arms, and then place a small cardinal or fluoropolypropylene suture at your preference to secure these lightly. And once that's complete, past the base of the needle and through the third arm or third port, placement of the right atrial wire, I like to place these medially, and this avoids any type of phrenic stimulation. And it's also very important for maze procedures, which we'll illustrate soon, as this allows for pacing a non-ablated area. Once this is complete, we'll pass the other needle end through the working incision and up through the number 3 port. And that concludes placement of the pacer wires. Now, very important is when you're reanimating, ventilate both lungs. And this avoids the challenge of unilateral edema. The final incision, this is 2 weeks postoperatively, still with the Dermabond glue left on the patient, with the final incision and positioning.
So now we've seen how to open and close the left atrium robotically, as well as put in epicardial pacer wires. These are the building blocks for all of the next steps we're going to look at. So join us in the next episode where we're going to start with a fundamental operation, and that is the excision of a left atrial benign heart tumor called a myxoma.